Our next activity will be a workshop where we'll be joined again by Dr. Ivan Lin, who'll be leading the workshop. Over to you, Ivan.
Thanks very much, Sid, and welcome back, everybody. Again, thanks everyone for joining in on their Sunday mornings. So again, just want to start by acknowledging the traditional owners of all the sites, all the country where people are joining in this morning. For me, here in Midwest Western Australia, I'd just like to acknowledge the Yamatji people and the elders past, present and emerging. So this workshop's entitled The Art of Clinical Yarning. Although this clinical yarning is a framework for communication in Aboriginal healthcare, whenever we present this workshop or this topic, people always say, "Oh, I could use this in my, with any patient," and we said, "Yeah, well, you can." And so I hope that for those of you who work with Aboriginal patients, I hope it's useful. But I hope for those who probably see fewer Aboriginal patients, I hope it's also useful as well. And just to give you a little bit of background of me, so I'm a physiotherapist, and by background, I work a couple of days as a physio and I work 3 days as a researcher. I live in Geraldton, Western Australia, which is about 450 kilometres north of Perth. Clinical work I do is for the Aboriginal Medical Service here, the Geraldton Regional Aboriginal Medical Service. I've worked there for about the last 15 years. Pardon me. And I guess I've been involved in musculoskeletal pain research with quite a strong focus in Aboriginal musculoskeletal pain for about the last, probably about the last 15 years as well. I was going to co-facilitate this workshop this morning with my colleague, John Bullen, who is from Curtin University down in Perth, and we had a number of meetings and caught up, and John is part of the ECHO team. But really sadly, some things have come up, unexpected things, and John's unable to be here today. So I'll be flying solo. You'll be stuck with me this morning. And I should also say that this workshop, I've not presented it by Zoom before, so it'll be interesting to see how this goes in terms of our interactions. It's a highly interactive sort of topic. I think that's the way it needs to be in order to get the most out of the workshop. And so we're going to be using the chat function a fair bit. And so I just wanted to start off just so I get used to using the chat function a bit. So I want you to quickly just jump on chat and just tell me the best thing about where you are at the moment. So if you want to just jump on and just to get your fingers warmed up. And so I feel reassured that the chat function is working, and so we can get that interaction happening. So the best thing about the place you are at the moment. Great. Thanks, Claire. Christian. Excellent. Oh, coffee. Yes. Oh, you got your dog. Great. That's excellent. That reassures me that chat is working and that I know how to use chat. Right. So let's make a bit of a start. So I'm just going to do a bit of a screen share and get this organised. So there. Okay. So assuming you can see my first slide there. So yeah, so would be presenting this with John, but yeah, sadly not here today. And so I just want to acknowledge the work of, well, firstly, of John, who wasn't on, who was going to be my co-facilitator here. But also I want to acknowledge Dawn Besselrab, Charmaine Green, Wanda Flanagan, all colleagues who the content I'm presenting today, we've been working on this material together for a couple of years. I also have a lot of other people I'd like to acknowledge at the end the presentation today. So to get you sort of thinking about communication, I want to start by playing a very short snippet of a pain consultation. And then I'm going to ask some questions for people to respond in the chat. So just have a listen to this short snippet.
Yeah, I'm up most of the night.
Does pain keep you awake?
Yeah.
Oh, sorry.
It aches and burns at night.
How do you feel in the morning?
Sore, tired, and it gets me down. I get grumpy with my family.
And your general health?
That's okay.
Are you a smoker?
Yes.
How many?
Half a pack a week.
And do you drink?
Sometimes a few. It helps me to sleep.
How many?
Okay. So just a very short snip of a consultation with a guy who has sort of back pain. So I want you just again to jump into the chat and just type some responses to this. So looking at that very short snip, yeah, of what you saw there, what do you think was effective in terms of communication? I'll see if I can juggle this so I can see what's going on in the chat. Okay. I'm going to have to, there we go. Yep. Yeah, so Jonathan, clear, direct questions. Yep, so succinct questions and some structure. There was some eye contact, that's true. Yep, okay. Let's go back to share. So what of that was less effective? Again, if I see if I can get the, oh, sorry. What was less effective about that little snippet there? Claire said for what was effective, he didn't seem to be typing notes. So I thought he was typing notes a little bit. Yeah, he did cut in with questions. Thanks, Jonathan. Yeah, he did interrupt Marissa, didn't he? And yes, very closed-ended questions. Thanks, Alexa. Yeah, yep. Thanks, Christian and Claire again. So yeah, it was very much that sort of firing those questions at the patient. And so you wonder how, what sort of quality information there was there. Yep. Yeah, exactly. Yeah, not much active listening. Okay, let's go back again. Thanks, everybody. We might skip the next bit and we'll. So yeah, so I think that little video really sort of highlights one style of communication. That's the style that certainly I think a lot of healthcare practitioners tend to use and are often tend to taught in. I think you can see there that from a content perspective, he was asking all the questions he needed to ask, but the way of asking the questions, you could see there were some issues there. You could see the body language of the patient. He looked like he was getting a bit fed up. The clinician there wasn't really picking up on those cues around body language. Questions were very closed, and it wasn't, overall, you'd probably say it wasn't that effective an experience in terms of communication, which is a problem because, effective communication is critical. So we know that there's a whole lot of research that shows why communication is important. So we know it's better at identifying patient concerns. We know it's associated with increased therapeutic alliance. That's associated with greater patient concordance. We know that more effective communication improves patient knowledge and health literacy. We know that it increases emotional support for the patient. And we also know that there are benefits from the clinician's point of view. So clinicians who are more effective communicators have greater satisfaction and well-being themselves. We also know that more efficient communication is more effective communication. And because you get to the nub of the patient's problem faster. And we also know it's associated with reduced complaints in terms of healthcare complaints, reduced litigation. And, in many cases when there are issues in healthcare, litigation is involved, then, the communication breakdown is part of that. So I guess in summary, effective communication is the foundation of evidence-based high-quality healthcare. But we know it doesn't always happen. So what I'm going to do now is I'm going to play you a very short audio of, this is an elder from here in Western Australia, just talking about what she understands about osteoarthritis.
I'm frightened I mightn't be able to walk.
Okay.
I'm frightened there come a time when I won't be able to.
Yeah.
That my joints will just go on me and I won't be able to do the things. I feel fear that I'll be in people's way if I have a wheelchair or push the things and I'm trying to, now that I'm older, to try and do things to prevent that from happening. Oh, I'm hoping it don't happen like the doctor told me when I done the test. I'm hoping that miracles can happen and it won't happen. I'm hoping that, no, I'm not going to.
So that was the doctor who said you need a hip replacement and nerve.
Yeah.
So it sounds like that worried you a bit.
Oh, it did.
Yeah.
It worried me.
Yeah.
So I'm like.
So you've been given that information from the doctors.
Yes.
What other information have you been given?
None other than the doctors.
Yeah.
They haven't been told much.
No.
Quite in the dark, really.
Yeah.
But I think that it needs to be more known.
Yep.
And aware about what it will do to you, what can you do to,
yep.
and when you been diagnosed with it,
yep.
Where do you go from there?
Yeah.
Yeah. Well, just given a medication,
yep. Yep.
and then where you go, and you're going, oh, okay.
Yeah.
That's it. That's all you get told.
Yeah, so I hope you could hear that okay. So you could hear that, that person was really worried about osteoarthritis. She was worried about its impact on her and the effect on her family. And clearly those fears and worries weren't addressed as part of her, contact with healthcare. So in that case, there was, an absence of communication. It's sort of, hers is only one story, but it really validates, the need to focus on communication and to improve that communication. And also really sort of also give some rationale behind the need for other ECHOS work as well, including the work that Brooke Connolly presented earlier on this morning, if you joined in, had the work of her PhD developing information that's accessible to people. So, that was an example of an elder here. But we know across the board, this is some of Sam's work. And, from this quote here, again, communication and deficiencies in communication underlies some of the issues that are going on here. Just let you read that. So communication is important, but it doesn't necessarily happen. So in the case of Aboriginal healthcare, again, a lot of research, some of which we've been involved with, we know that these are some of the issues. You would have heard some of those in that clip there. And we know that there's some mistrust. We know that use of jargon tends to alienate Aboriginal people in healthcare. We know that experiences of racism, different worldviews, language barriers, sometimes absence of communication. We know that these have quite significant consequences for patients. So we did a systematic review a few years ago. Some colleagues here included Sam and some others, and we found that one of the we identified that access, the burden of musculoskeletal pain conditions is higher amongst Aboriginal people. We know that access to care is lower. We know that one of the main barriers is ineffective communication. So it's a real reason why people choose to walk away from care, and probably downstream this contributes to worse health outcomes. So it's a bit of a problem. And so we can map that out in terms of what's going on. We know that the prevalence and burden of osteoarthritis is higher. We know that communication barriers prevent access to high quality care, culturally safe care. And so it raises the question, what does better communication look like in practice? And then this idea of what tools and frameworks can assist clinicians. And that's really what this presentation today is about, and what's going on. And what tools, what's there to help support clinicians deliver culturally safe, culturally secure care for Aboriginal patients with osteoarthritis. All right, so already had a break. So if you're sitting down as I am, and this is about the 20-minute mark, what I want you to do is just to stand up and sit down 5 times. And I'm going to be relying on trust because I can't see you. And I want you just to jump up and down or twist or move, something like Dave Hall from the APA does, and just to get the body going again, just for 5 seconds. I'll do the same thing myself. All right, let's move on. So this leads to the whole purpose of today's workshop, really. What is better in terms of clinical communication? And this leads on to the notion of clinical yarning. So clinical yarning, most people know what yarning is, but essentially yarning is a term that was adopted by Aboriginal people, and it's about conversation. It's about having a two-way conversation where where two people are engaged in communicating on equal footing. And so clinical yarning is really borrowing this idea of yarning and applying it to the clinical context. One of the things we sometimes hear about yarning is, oh, well, you just can't spend all day yarning with patients. And that's true. Patients see you for a reason. You see the patients for a reason. So clinical yarning is very much a yarn with a purpose. And the intention is to make the yarn, by using the yarn, is to make the consultation more friendly for Aboriginal and culturally safe for Aboriginal patients. And so it's really, I guess, the operationalisation of culturally safe, culturally secure care by applying, patient-centred communication approach in Aboriginal healthcare is what clinical yarning is. And it consists of 3 parts. So, and we'll talk through each of these parts. So it consists of the social yarn, the diagnostic yarn, and the collaborative management yarn. And so probably a preferred way to depict these is really looking at, this is my colleague Wanda's Yamaji depiction of this in terms of the social yarn, the diagnostic yarn, and the management yarn. And so if you think about clinical communication as 3 parts, Wanda painted this picture, and what she talks about is she used white as a colour because she said it represented clinical spaces, and for what she terms the sort of sterile feeling and the smell of clinical spaces. The person on the left, you can see is with the white dots around, is the clinician. The patient is the other person. And what she talks about is the clinician and the patient together sort of walking through this consultation journey through the social yarn, the diagnostic yarn, and the management yarn. So what I want to do now is just talk about each of these in turn and explain this sort of model of communication. So first of all, the social yarn. So the social yarn is really when you first, well, it doesn't always have to happen first, but it's about developing relationship and trust with the patient and really trying to make the person feel comfortable. So the social yarn is when the person walks in, and it's sort of what sometimes might be called pleasantries, but it's really about trying to indicate and signal to the patient then you're interested in them as a person and you're developing a connection as a person as opposed to them being the osteoarthritic knee or the frozen shoulder or their condition, okay? And it's for each of you to know where you're coming from. So what we're going to do now, just to sort of get a handle around the social yarn, we're going to try and set up and have a virtual social yarn. So I'll be relying on the IT support to do that. So what I'm wanting to do, and hopefully Michelle's out there can help me, wanting people to break away into small groups. You'll be put into breakout rooms. And I want you, when you're in that room, hopefully 2 or 3 people, what I want you to do is have about a 4-minute social yarn with the person, okay? So hopefully, Michelle, you can assume control and send people now to breakout rooms for 4 minutes now. And we'll come back and talk about it.
Hi, is anyone listening from Opus support?
Yes.
Yes, we're here.
Yeah, hi Basil. Are you able to just pop me back in my breakout room? I had to go and change a setting and it's kicked me out. Sorry.
Yep. Okay, I wonder if we can bring people back, Michelle. Right. People are still making their way back slowly. How are we going to bring people back, Michelle? Thinking we might need to get moving. Oh yeah, give them a minute, you reckon? Okay. People are coming back, excellent. Just wait for a few more people to reappear and then we'll get back to it. Hello everybody again, it's nice to see everyone's faces when everyone comes back. So I want you to jump on the chat there, those who are back, and just quickly type in what you yarned about. Just quickly note a few things about what you had a yarn about. Yes, the weather's always a good one. Family, kids. Yep, that was a nice yarn, Sam. Yep, about our shared experience at the forum. Lupus, that's great, thanks Leanne. Keep typing in for what you yarned about if you like. But also I want you to start to think about, thanks Jonathan. So people are talking about about their work, COVID's always a big one these days. Think about what skills you used to get to that point. So what communication skills did you use to get to those yarning topics? What did you do? So think of skills. Skills might also be what techniques you used, what strategies you used. How did it start? What did you do? How did you get to be talking about your family or the weather? Yep, said hello, introduce yourself. Thanks, Marissa. Introducing yourself is a good starting point. Yep, ask questions. Yeah, conversational leads, so cues for communication. Yes, so those pleasantries. So when you say, usually people start with an open question as well. It's common. Thanks everybody. Let's go back to, so that was a bit of a virtual social to get, and obviously everyone on this forum has quite a lot of things in common, and we're all part of the Opus forum. We all are involved in osteoarthritis and interest in osteoarthritis. So the social yarn, the skills, if you think about the skills for a social yarn in the clinical yarning model, so you have an Aboriginal patient, skills are not too dissimilar. So it's really about introducing yourself respectfully, being open, friendly and interested, finding common ground. That's a big thing. And when we've presented this, particularly to medical audiences before, we've had quite a lot of pushback. When people say, oh, we don't, as healthcare practitioners, we have to stay back. We think this is a critical skill in clinical yarning to give some information about yourself, using humour if it's appropriate, using an open body language, demonstrating curiosity or an understanding if you have it, if you've done some, if you're culturally aware, demonstrate an understanding of Aboriginal culture can be very useful. And depending on where you're working, having some good skills to work effectively with cultural intermediaries such as interpreters or liaison officers. So the social yarn, we should say that these are the some of the key skills we think are important for the social yarn. There are a whole lot of other skills that you use as part of patient-centered communication. But these we think are some of the key skills. And that common ground thing is one of the most important. What I want to do now, just to illustrate that, is just play a little video from a project we're doing with some of our partners in Queensland. We're looking at implementing clinical yarning in some pain management centres, pain management services in Queensland. And I want you to just have a look and just see if you can pick out the what skills are used in the socio-yarn in this video. It's only a short snippet.
Ivan, I just stopped your sharing. When you share, just share your audio. So there's a bottom left where it clicks share audio or
Okay.
computer sound.
Thanks. This should be a video though. I'll try it again. Thanks for letting me know there. All right, trying again. Apologies about that.
G'day, Colin. My name's Andrew. I'm one of the physiotherapists here at the Pain Management Centre in Brisbane. So thanks for coming in today. How are you going?
Why, all right. It could be better, you know.
Yeah.
Back pain sore. Give me plenty of trouble. Pain. Come all the way down and down my leg.
Yeah. Sounds pretty uncomfortable. Can you tell me a bit more about that? You know, when it started?
Well, I've been working since I was 15. Hard work. I will crook back from time to time, but you become good. I hurt my back a while ago. Ended up having surgery, but bad ever since.
So what work were you doing then?
Fencing work, stock work, just working on farms. Hard work. Used to work but play hard too. I played league too until I heard it then.
Okay, league. So you look like you could be a lock. I was a winger when I played league.
No, I'd be centre. I could run fast back then.
So you're a Broncos supporter?
Yep. I have to go for Broncos because my dad go for Broncos. But I grew up in the Straits and Cairns, so I got soft spot for Cowboys.
Yeah.
Okay. Yeah, apologies about the video then. I was happily watching the video and got quite engrossed in it, but hopefully it worked that time. So you might have seen there, just a bit of cross-cultural interpretation for Victorians. League, they're talking about rugby league. It's a different game to AFL. Looking at that video there, just again type in the chat, tell us about what was the socio-yarn about there? What was the topic of the socio-yarn? Yeah, that's right. So the shared experience around sport and rugby league. That's right. Yeah, that's right. Thanks, everybody. So getting to that socio-yarn, what skills did he use? So you would have seen some of the skills there. If you can think of any, type them in. But really, it started off with the diagnostic yarn. He was asking about his clinical condition, asked about, his pain. And then there was a cue there for the socio-yarn. So then it transitioned into the socio-yarn. So one of the things about the socio-yarn is that it's really looking for those cues, and you can see the body language changes, you can see people's interest changes. And obviously in that case, Torres Strait Islander man, and yeah, so Queensland context, that was the socio-yarn. Yeah, that's right. The cue then leading into the socio-yarn. So my colleague, Dawn Vassarab, she talks about having a map, a socio-yarn or conversational map, and she says it's based on cultural awareness. So if you're culturally aware, if you know a little bit about Aboriginal cultures where you are, then you have some idea of what might be culturally valued in that area. So for example, where I am here in Geraldton, there's a place called Shark Bay, which is about 4 hours up the road. A lot of people in Geraldton, or a number of people from Shark Bay live in Geraldton. And so if I see a patient who's from Shark Bay, I'll recognise a surname and know they're a surname from that region. Often the social yarn will go along the lines of, oh, so if you've been home recently, I'll ask them, they say, yeah, I've been, or haven't been home for ages. And I said, oh, well, if they've been home, I said, oh, been fishing. Shark-based coastal community. Fishing is very much part of the way of life there. And so it's, saltwater people. I just spend a lot of time in the ocean too, and we'll have a yarn about fishing or something along those lines. So it's linking that sort of cultural awareness to the social yarn and to sharing some information about yourself. So that's the social yarn. I hope that makes sense. And so really it's about, developing that relationship first of all, very important. Okay, let's move on to the other areas of. So after the social yarn comes the diagnostic yarn. And the diagnostic yarn is really that part of the consultation whereby you're gathering the clinical information you need. So it's, you've got a whole list of information you need about that person's pain and what treatments they've had before and how the pain impacts upon them and all that sort of clinical information, if you like. But the way you go about it, so that's your content, but clinical yarning is very much about what skills you use to do, what process skills. And so what you're trying to do is facilitate the patient's health story in that comfortable conversation using the yarning style. But all the while you're doing that, you're filtering that information with pulling out all that information you need in order to understand that person's condition, in order to interpret that person's condition. So skills for the diagnostic yarn. So diagnostic yarning shares a lot of similarities with narrative-based approaches. And so it's really about those open-ended questions. It favours open-ended questioning. So obviously, sometimes you might need to narrow it down if there's some specific things you need to check. But it favours that open-ended questioning. It's really using that active or deep listening, and particularly that's non-judgmental. Silence is something that often, many healthcare practitioners aren't particularly comfortable with, but in the context of clinical yarning, giving the patient some time and some space to think about an answer is really important. Recognising both verbal and non-verbal patient cues. You saw in that example before of that video, that picking up on the verbal cue and then that transition to a social yarn, and then you transition back into the diagnostic yarn. Using those reflective communication skills, validating, summarising, prompting, clarifying, so to signal to the person that you're really engaged and really listening to their story, and by doing that, providing empathy and support. So, so the diagnostic yarn, it's the same content, but it's the way you approach it, using very much that yarning style and that deep listening style. All right, moving now on to the management yarn. So the management yarn is really about explaining health information in a way that makes sense, because if you explain health information in a way that sort of resonates with that person's life experience and makes sense to that person can be engaged in developing the management plan together. So in that sense, the management yarn sort of shares some, borrows from sort of motivational sort of styles, because you're really helping the patient to identify their own strategy ideally. And it's based on explaining health information in ways which is contextually meaningful for the person. And so I'll talk about some examples in a second maybe. So skills for the management yarn. So hopefully by the time you've got to the management yarn, you really have an understanding what the patient knows about their health issues. So you can pitch, you can pitch the sort of information at the right level. And I certainly know that I've made some assumptions before, and I've had patients who have very kindly stopped me when I've been entering onto this. Okay, I think I'm explaining things in the right way. And someone stopped me and said, "Oh, hang on, stop. Now, Ivan, you know that I'm a nurse." And I've gone, "Oh, sorry," and then I need to reset and then start again by explaining things. So the idea is to provide direct, straight-up health information, to remove all that healthcare jargon that we know that practitioners can get in the habit of using, What's really important is using a variety of explanatory aids. So stories, metaphors, visual aids, models, and again, it's customized to the person. Metaphors can be really helpful. We work with a guy called Ted Dowling, who's a cardiac nurse and runs a cardiac rehab program at WA Oregon Health Service down in Perth. And he has these metaphors he uses when he's trying to explain angina and heart attack to patients. Now he's based in the city and he uses the traffic network. So he says to patients, so the freeway, the Mitchell Freeway, and all the cars racing down the Mitchell Freeway, think of that as your blood flow. So that's your blood flow racing to your heart. And he says, so he asks the patient, so what happens at peak hour to traffic? And the patient says, oh, traffic slows down. And Ted would say, yeah, that's right, it slows down. So, the blood's still getting through, but it's slower. And that's like angina. And then he says, so imagine down the Mitchell Freeway, you've got a semi-trailer, and all of a sudden that semi-trailer rolls over and blocks the traffic. What happens then? The patient might say, oh, no traffic gets through, there's a traffic jam. And Ted goes, yeah, that's right, that's a heart attack. And so, when there's a heart attack, all the traffic stop on the freeway, it's like your blood stopped at the heart. And so what we need to do is we need to put a bypass around that bit of traffic. And then Ted, depending on where the patient lives, he'll go into this big sort of discussion about what roads he would bypass with, and then he aligns that with bypass surgery. So, I mean, that's a technique he uses for metaphor. But there's a whole variety of metaphors you can use. So after you've done that, it's then important to check and use that talkback message, asking the patient, so when you go home and you see your auntie or your cousin or your sister, and they ask you what's going on with your knee, what are you going to tell them? And so that talkback can be, as many people here I'm sure would know, it can be quite a good leveler in terms of how effective your communication is. So again, what I want you to do now, so thinking about that, thinking about the management yarn, I'm sure everyone here has a whole variety of metaphors and ways they explain osteoarthritis to patients. Do you want to just, I might get the chat up again, and what I'll do is I want you to type into the chat some of the techniques and strategies you might use for management yarn for a patient with osteoarthritis. So just type in there. So are there any particular metaphors you use? Are there any particular techniques you find helpful, the management yarn? Just type it into the chat there for me. I don't know, after Sam's talk earlier on this morning in impairment-based models, I sometimes do use the metaphor of a car's universal joint and the grease inside of it, and what happens with the grease of a car that's been sitting idle for a long time in someone's backyard, and the grease gets all stiff, and then you need to get that grease moving again to get the, as I use that sometimes a metaphor for me, but I'm not sure if that's helpful for an impairment-based model, as Sam was talking about. What sort of metaphors do you use? The Pantene commercial. That's a nice one, actually. I quite like, yeah, those little sayings can be quite useful for patients as well. The motion is lotion and those sort of things as well. Any other metaphors people use to explain, say, a sore knee? That's great, Christian. I thought you might have some nice ones. Yeah, that's great. That's an excellent one. All right, very good. If you've got any others, just type them in. I think it's really nice to share ideas. So, I mean, we talk about, when we do clinical yarning, and I'm sure people do that already, it's good to have a variety of different strategies in your toolkit. So when the patient comes in with a particular condition, and they're a particular, according to the sort of patient, then you've got sort of a variety of metaphors you can then use, or a variety of strategies you can use in management yarning. And keeping, I'm sure people do this, but keeping a sort of suite of various online resources you can send to people as well to reinforce what you've said. All right, let me share this again. Okay, so that is the management yarn, and that is the model. What I'm going to quickly talk about now is some of the work we've been doing implementing clinical yarning. And then hopefully we might have a quick chance to have, it's a bit hard to yarn with a big group, but we might, after we've done this, perhaps we can get people to come off and just have actually hearing your voices would be lovely, rather than just seeing the type as well if people have got comments or suggestions or questions. So, so that's the model. So we've done a couple of projects related to clinical yarning. So we did a pilot study and trained, implemented clinical yarning with something like 34 or 35 staff from a whole variety of different areas. We did it with a remote healthcare service. You can see the top left photo is in a remote hospital, which is about 700 kilometres inland of Geraldton. We've done it with staff from the emergency department. We've done some clinical yarning training with mental health staff. We've done it with staff from Aboriginal Medical Service. And so what we've been doing is really delivering these clinical yarning workshops, half of which is sort of an extended version and with some examples and similar to what the content that I've talked about very briefly today. And then the other half of which is doing some simulation with what we have done is train some Aboriginal community members to be simulation patients. And then people would then have a go at using those clinical yarning skills with a community simulation patient who has been given a scenario, a healthcare scenario that they play the role of. What we know very clearly from communication, patient-centered communication education is that you can tell people and then their knowledge will change. This is probably the same with lots of areas of healthcare. But if you want their behaviour to change, they need to practice it. Need to do it. So that experiential aspect of learning. And so, yeah, the workshops we've done very much focus upon that experiential learning side of things. We also have some other projects. We've done some training. We've done some 2-day training for clinical yarning facilitators from each region of Western Australia. Whereby we train them to deliver workshops and deliver the sort of simulation education training. I also mentioned briefly a project we have at the moment with Queensland pain units through QIMR in Queensland and partners at Queensland University. And that's looking at implementing clinical yarning in some pain management services and looking to see if there's any changes in patient experiences of care and clinical outcomes as well as practitioner outcomes. So we should have that data by the end of the year with a bit of luck. So we know the results from our pilot study. So we've done a mixed method evaluation. And we know, as you would hope from a workshop, is that people's self-rated communication skills, ability, confidence, knowledge, and importance of communication training in Aboriginal healthcare increases significantly. So that it's very preliminary information, but it shows, we need to have that step to know you're moving in the right direction. So from the participant point of view, it seems to be valued and people feel they're learning something. I quite like this quote from one of our participants because it really echoes one of the reasons why we think clinical yarning is important. We think often people learn about cultural awareness training, for example, in healthcare, but then the next step is operationalising it. And clinical yarning is a way of operationalising some of that cultural awareness training into clinical skills. All right, so where are we for time? We're almost finished anyway. So look, if you remember nothing else from today's presentation, I want you to remember Wanda's painting, which is of the frameworks of the social yarn, the diagnostic yarn and management yarn. If you Google clinical yarning, you'll find a paper, it's open access, that we published about 5 years ago, which talks a little bit more about the model, if you're interested. We have an e-learning program for sort of, if you like, the theory aspects, which is, we're migrating it to a different learning management system at the moment, and that's clinicalyarning.org. So if you keep your eye on that, it's only in draft form, that'll be available as well. And I just want to quickly thank all of these people, our collaborators in Western Australia, Northern Territory, and the UK, who are experts in patient-centered communication and members of our Queensland team. And again, to acknowledge John, who we had some good yarns about this workshop today, but yeah, unfortunately, John's some unexpected things came up and couldn't be here. So that's how you can get in contact with me if you'd like to. So thanks very much. And I think we're probably going to run out of time now. So I'll pass back to Sid. Thanks very much.
Great. Thank you, Ivan, for taking us through clinical